Welcome. Thank you for being part of this. This is Train the Trainer. My name is Rick Titus. I'm a family doctor. I'm a former pharmacist. And what we're doing today is we're talking about obesity. And our patients come into the pharmacy. Our patients come to the family doctor and they say, please help me. And who are the patients coming to? Well, a recent study shows that patients, who do they come for their health care? Do they see their physicians? Do they see their pharmacists? Well, studies have shown that 92% of patients go to their pharmacist. Well, I want to share some information for you today. I want to share some information about obesity. And obesity is an issue that's 20 years ago wasn't prevalent. Today it's an issue. Today we have to be able to help our patients deal with obesity. Obesity is a disease. It's a chronic disease. It requires a lifetime intervention. So working together, physicians, pharmacists, we can deal with this disease. When you're doing this presentation, I would recommend that you get your audience, invite your audience to belong to CON. CON is Canadian Obesity Network, and it's designed for healthcare professionals. There's all sorts of information there. There's all sorts of slides. So please have them go to the CON website. Now, Arya Sharma is the head of CON. Tom Smiley and myself have delivered a number of these presentations. Tom Smiley is a pharmacist in Ontario. And what we've been doing is, I'm also part of a family health team. In my family health team, there's 115 doctors, and we have pharmacists in the community, pharmacists in our clinics. Now, can you imagine having 115 doctors working together? Well, generally you have 2 to 3 doctors, and they have about 10 opinions. But one thing we agree is that the pharmacists and doctors have to work together, have to have an integrated approach. And that's what we try to develop. Now, when you're presenting this to your group, I think these are going to be the learning points. If you take a look at, we want the health risk associated with overweight and abdominal obesity. So we're not only interested in the obese population, but the overweight. Studies have shown that if you don't get people when they're overweight, they're going to proceed to obesity. So our focus is overweight and obesity, and in particular the overweight with comorbidities. Comorbidities such as blood pressure, such as diabetes. And discuss the opportunity to become more involved. This is all evidence-based. The significance of evidence-based is people will come to you and they say, what about this product? What about that? I'm going to this clinic, to that clinic. This is all evidence-based. So the information here is all validated. Now, if you take a look at here at the demographics, well, was obesity an issue in 1985? Was obesity an epidemic? So again, if you take a look right across Canada, it wasn't an epidemic. The definition of an epidemic is when 20% or greater of the population is affected. So in 1985, we were not in an obese epidemic. But what has happened since? In 2004, if you take a look at here, right across Canada, we have an obesity epidemic. And then someone from your audience will say, well, what about BC? Well, the good news and bad news. In 2004, they weren't obese, but now, 2008, BC is also greater than 20%. So we're from coast to coast. Now, people are looking at this, and the significance to your audience of this particular slide is this. Only 34% of males are at their target weight. So what we're telling is that 66% of the population is overweight or obese when it comes to males. And just on the side, did you know that Canadian males are the most obese in the world? Now, isn't that amazing? So we're number 1. But I'm not sure we want to be number 1 in that area. Now, what about our children? Look what's happening to our children here. In 78, 79, 17%. This is what you have to focus in. 17% were overweight or obese. Look what happens in 2004. We've got 27% are overweight or obese. So what are we saying? We're saying 1 out of every 4 child is overweight or obese. But if you take a look at this data a little closer, you look at approximately 4% were obese in 78, 79. But look what happened in 2004, 9%. This is more than doubled. Studies have shown that if you have an obese child, what happens when they become an adult? 90% will become obese adults. What about diabetes? Does that impact on diabetes? Do you have obese children? Well, 1 out of every 5 new diagnosed diabetic is an adolescent or someone in their early 20s. So is obesity an important issue? Absolutely. Now, this is one of my favorite slides. And when you're presenting this to your audience, everyone seems to appreciate that, oh yes, obesity does affect coronary artery disease, does affect diabetes, does affect dyslipidemia, does affect hypertension. But the question to your audience is going to be, what does obesity not impact? Like, let's take a look at osteoarthritis. Did you know for every 10 pounds that you're above your ideal weight, there's an effective increase in your knees, the medial aspect, of 4 times. So that's 40 pounds. So if you're 20 to 30 pounds overweight, we're talking an effective 80 to 120 pounds of extra pressure on your knees. So are we seeing more joint replacements? Absolutely. Are we going to see more as time goes on? Absolutely. What about sleep apnea? Sleep apnea, 20 years ago, did we have sleep apnea? No. Now your customers are coming in and saying, geez, I've got sleep apnea. I got gastroesophageal reflux disease. What is this all correlated with? Obesity. And look at cancer. Some cancers are increased by 50%. And I routinely tell my patients, if you want to decrease your chance of cancer, what do? 2 things I recommend. First, stop smoking. Second, what you have to do is decrease weight. And that's key. Let's take a look at the correlation between BMI and cardiovascular mortality. And if you look at here, so this here, if you look at 25 plus, look at right away at 25 plus, you're looking at the relative risk of death. Even being overweight is an impact. So when you have your customers there and your customers say, well, I'm just a little bit fluffy, well, you have to start addressing that. So when you're doing this presentation, why don't you get someone to come up as a volunteer? So is there any volunteers in the audience that are willing to have their waist circumference? I don't have to mention your waist circumference unless you want me to. Any volunteers? Oh, there is a brave soul. Please. Notice it's always the skinny volunteers, okay? I've never had an opportunity when someone that was a little fluffy coming up. Okay, so again, when you're measuring this, and perfect, just have the person just totally relax, just standing straight, totally relax. And then what you do is again, you're just at the side here, and you're looking at the anterior iliac spine right up here, and then you just, and then, okay, and then you're talking to the individual, so making sure that the person is relaxed. And then let's just see, look at my, Now, this is excellent. Congratulations. You are at the ideal abdominal circumference.
Thank you.
And that's it. And the significance of this is that when you've got the landmarks, and then you have the patient come back in a month later, and you measure it again. So it's always based upon the reference is that same patient. Waist circumference, is there correlation with abdominal obesity and type 2 diabetes? Absolutely. Here it is. Look, if anything above, this is like 71 centimeters. This is like 26 and a half inches. So anything above that, there's an increased incidence of diabetes. So abdominal circumference on its own is a risk factor. So look, first thing is physical activity. And when I say physical activity, I mean activity. I don't call it exercise, because you have to caution when you're talking to your patients, because when you talk to your customers and you say, hey, Jim, I want you to go exercise. Well, I told that to one of my patients. He's 54 years old, works at the steel plant, and he's about 5'6", 186 pounds. And he said, Doc, I can't do it. And I says, why not? He says, Doc, I look really bad in spandex. So the issue is that not exercise, not everyone can join a club, but everybody has a pair of running shoes and they can go for a walk. So the focus is activity. And when we're talking about activity, you have to talk to the level of your particular patient or customer. So something that he can enjoy doing, not only for a week or two, but for forever and a day. We're talking about lifestyle, diet, and then the next step moving up the chain is pharmacotherapy. Pharmacotherapy is, again, very important, but pharmacotherapy is in addition to diet and physical activities. Go hand in hand, long term. Now, if those two don't work, then you may have to go to bariatric surgery. Some patients require surgery. A good analogy is if someone has an elevated BMI and he's a diabetic, hypertensive, and he's BMI of over 40, and telling him to eat bran is not going to help him. So you have to have the surgery. And the interesting aspect of this program is, so your patient has a gastric bypass, the patient comes back to you. So how does that impact on his drug medication, on the pharmacotherapy, on the bioavailability of drugs? Well, this is something we're going to discuss later on in the program. General approaches. So your customer comes in, and it's important that the intervention should become early. Because if you're in your 20s and you're overweight, what are the chances of being obese when you're in your 30s? 90%. So again, every patient, every customer that comes in, we have to spend the time, we have to educate them. And it's important that you're not only involving the patient, but also his spouse, family, friends. And also, we're not interested in rapid weight loss. We're not interested in short-term diets. So if the patient is on medication, I think it's important to encourage the patient to remain on the medication long-term. It's sort of, a lot of times the patients, they lose their 10, 15 pounds and they say, well, I'm cured, I'm going to stop. But if you take that analogy to blood pressure, if the patient reaches their blood pressure in 2 to 3 months, do they stop their medication? Absolutely not. The same thing applies to pharmacotherapy when it comes to obesity management. Also, it's nice if you have a team approach. It's nice if it's the pharmacist, the family doctor, the dietitian, you have social programs in the community, so we're all working together and we're working on the same page. This program here has been presented to family doctors. You're presenting it now to pharmacists. So the idea is that there's powers in numbers and we're working from the same script. Now look at this. Wow, caloric, eating more of everything. Caloric intake. Does caloric intake impact on obesity? And this is an interesting slide because you look at this slide in 1970, the average Canadian consumed 1,500 pounds. Amazing. And if you take a look at the breakdown, pretty impressive, but pretty healthy. But look what happened in 2000. the average person 1,775. And you can tell your audience what's happening now in 2008. How much do you think the average person's consuming? 2,000 pounds. So that's a ton of food every year. So our caloric intake is increasing. So I'm saying what we're now suffering from is a new disease, and it's called hypernutrition. We're eating all the right food, but we're eating too much of it. So over the last 25 years, we've gone from 1,500 pounds per year to 2,000 pounds per year. But what about our energy? Are we walking more? Are we becoming more active? Did we have dishwashers back then? No. So our energy output is going down. Our consumption's going up. So what's the result? Now, another interesting fact, that did you know that this is the first time in mankind that obesity has overtaken malnutrition as a major cause of death? This is the first time in the history of man. So again, it's important to get this information out. Canada Food Guide. Is the Canada Food Guide great? Absolutely. But it has its limitations, okay? And it says 5 to 10 servings of vegetables and fruit. So again, I have patients coming in to see me at 10 o'clock in the morning, and they say, geez, doc, I've had an apple, an orange, I've had some kiwi, I have some plums. This is like 10 o'clock in the morning. So if at 10 o'clock in the morning they've eaten that much, so what their response is, I'm following the Canada Food Guide, right? So again, what's happening is the Canada Food Guide is really geared to someone of normal weight. So the Canada Food Guide is good, I would say, not for the 66% that are overweight, but the other 34%. What I like using is here, the American Food Guide here. And if you take a look at this pyramid here. The bottom of the pyramid is daily exercise. So this is the first time in the food pyramid or a food guide that we've incorporated daily exercise. And what about fruit? 2 to 3 servings a day. Does that make sense? I think so. And vegetables, an abundance of vegetables. Common sense. So I think this is something that you share with your patients or customers. Now, what about, we saw on the other slide, what do we see? We're consuming more calories, right? Every year we consume more calories over the last couple of decades. But what about activity? What's happening in terms of activity? This is physical inactivity. So a 12-year-old, 30% are physically inactive. And in every decade it increases to the point, if you're a 65-year-old female, 60 to 70% are physically inactive. Now, let's talk about the pharmacological therapy. Now, who should we initiate pharmacological therapy on? Well, if obese patients. But what about the overweight patient with comorbidities? What about the overweight patient that has diabetes? What about the overweight patient that has hypertension, cardiovascular disease? Well, these are some of the patients you have to consider. And what's available? Right now in Canada, there's only 2 compounds available. There's orlistat that will decrease or inhibit absorption. There's sibutramine, which is appetite reduction, satiety enhancement, and increased metabolic rate. Now, we suggest the addition of a selected pharmacological agent is appropriate for overweight and obese adults. This is part of the Canadian guidelines, Canadian obesity guidelines. This is a grade B level 2. Now, what is very interesting, look at this, Canadian Diabetes Guideline 2008. So it's important for you to stress this, that this is the first time in the Canadian Diabetes Guideline, they've come out and said that appetite suppressants are an important role in the treating obese diabetic patients. And again, what we have to, it's important that we instill in our patients is that it's not a 1 month, 2 month, 3 month, it's a long-term treatment plan. So if we look at Orlistat, Orlistat prevents absorption of dietary fat. Orlistat is taken 1 capsule 3 times a day. Now, I was involved in this particular study, and what you have here is the placebo arm. And in the placebo arm, there's a 6.1% mean weight loss. This is significant because I said our goal is 5 to 10%. So is this significant? Absolutely. Now, this group here, how do they lose their weight? Lifestyle modification. So again, this stresses lifestyle modification is important. This group here was put on the active medication, Orlistat, and they lost 10.2%. So the difference is statistically significant. What about sibutramine? How does sibutramine work? And there seems to be questions on what is sibutramine? What class of drugs does it come under? Now, sibutramine is an SNRI. Now, people say, well, an SNRI, a lot of pharmacists will phone me up and say, well, isn't it like Effexor? Absolutely. Or Cymbalta. So it's in that class of drugs. And what that does, it inhibits reuptake. So here's this chart. So unlike the historical appetite suppressant medication, it is not a releasing agent. But what it is, it's a reuptake inhibitor. So you hear sibutramine here, it inhibits the reuptake of serotonin, noradrenaline. And here's fluoxetine, which inhibits the serotonin uptake. And again, if you look at Effexor, Effexor will inhibit serotonin, noradrenaline, and Cymbalta also. So it belongs to that class of medications. So the side effects of that class of medications, I think we can all appreciate. So what are the side effects? Well, the biggest side effect is dry mouth. And it's important when you're dealing with our patients, with your patient, is this is a transient side effect. I tell my patients ahead of time, you will have dry mouth, and this will last for a couple of weeks. And if the patient is aware of that ahead of time, the patient is quite happy to tolerate that. But it's important up front to tell them about that particular side effect. Now, this here is a STORM study. And what I'm very impressed about this study is, if you take a look at the length of time, it's a 2-year study. Okay, so again, the focus is this is not a short-term fix. This is long-term. So if you take a look at here, what everybody was on sibutramine, and you look at the weight loss, very effective weight loss. And again, we're looking at 5 to 10%, very effective. Then at this point, at 6 months, you have the control arm, and the control arm was on placebo, and you have this arm here that continued on the sibutramine. Look at the impact from 6 months to 24 months. So you had a plateau of the weight, whereas the control arm was increasing again. So this demonstrates the importance that once you've lost your weight, then you have to continue the medication. So again, emphasize, is it a short-term fix? No, it's long-term. And that's consistent with Canadian Diabetic Guidelines, with the obesity guidelines. The SCOUT study, this study is a fascinating study. This study is going to be released in November of this year. Because if you look at the criteria, there's 10,742 patients, and these are high-risk patients. Because when you think of Meridia, if you look at the product Monograph, it excludes a lot of the patients that would benefit the most. But with the SCOUT study, they purposely went higher risk patients. So you're looking at 97% had cardiovascular disease, 88% hypertension, 84% were type 2 diabetic. So the only information we have now that we have the 6-week run-in. So the full study will be released in November of this year. So first 6 weeks, what we found, that within 6 weeks on sibutramine, there is a waist circumference loss of 2 centimeters. And patients discontinued it if blood pressure increased by 10 millimeters or if the heart rate increased by 3.5%. Now, majority of patients had less than 140 and 90 that were decreased or that were discontinued. And that's a very interesting comment, because what they found in this particular run-in was that the patients that had the highest blood pressure, those patients did not have an increase of blood pressure at all. But what they found was some of the patients that had normal blood pressure, they had a transient increase in blood pressure. This is lifestyle modification to be included. Now, what this shows, I think what we're not surprised, because here the combination of medication and lifestyle, you have the biggest bang, okay? You get 12.1 kilos lost. So it shows you that it does have impact. Counseling, lifestyle modification, and medication. But what was interesting, that if there is brief counseling, even to the fact that the patient would come in, just briefly say to you, well, how's your weight? So just a brief encounter with a healthcare provider also added benefit, added value. Okay, the class of serotonin noradrenaline reuptake inhibitors, what are they? Well, we've got Effexor, we've got Cymbalta. Now, what I think it's important to appreciate, what are the side effects of SNRIs. Side effects of SNRIs are for dry mouth, first of all, and it doesn't matter if you're talking about sibutramine, if you're talking about venlafaxine, they're all the same. So it's something that you have to advise our patients, our customers. You'll be experiencing this. And I think that you have to focus on the fact that these are transitory side effects. Now, we also were looking at, what about the cardiovascular effects? But if you take a look at, what about increase in blood pressure? Well, drinking coffee will increase your systolic blood pressure, what? 314 millimeters of mercury. Now one thing that when you're dealing with the pharmacist in your room here, you tell them, well, how many people have had a cup of coffee? 2 cups of coffee. Well, their blood pressure will be increased just from the coffee, just from the caffeine. But look at here. Duloxetine causes a 2 millimeter increase. Venlafaxine, 2.375. Sibutramine, 2.7. So this is part of the class. And if you're looking at heart rate, 2 to 3 beats increase. So really not a significant, but it is expected. So I think one of the issues we have to bring up with the pharmacist is, when your patient comes in on Effexor, do you address the issue of blood pressure? Do you advise them about dry mouth? Because if you don't, I think you should. Well, you've got the person on a diet, the person has increased his activity, he's on medication. What do we do next? The patient he's got a BMI of 40 plus. What do we do? Well, the next step is bariatric surgery. And for a pharmacist, this is very important, because when your patient comes back to you after having bariatric surgery, what are you going to be doing? How can you counsel them about their medication, about their current blood pressure medication, about their diabetic medication, about absorption of medication? So this is an important issue. So right now, the bariatric surgical procedures, what we have, the most common one is adjustable gastric banding and the Roux-en-Y bypass. Now, if you take a look at the gastric banding, if you take a look at, this data is 6, 8, 10 years out. Is there a change in body weight? Absolutely. You're looking between 15, 20% long term. gastric bypass, you're looking between 25 and 30%. And if you take a look at gastric, if you look at the gastric banding, what it is it's an amazing procedure. What they do is they go in and then they put this band around your stomach, and then they bring the stomach over and they just tack it in, and then there's a tube going out and it's just underneath the skin. And so what happens is then you go to your doctors and you can say, well, you can increase the tension or decrease the tension by injecting saline or taking saline out. So I have one patient she came to see me. She's had this gastric bypass and banding, but unfortunately it's not covered in Ontario. I don't think it's covered in Canada. And so she's coming to a cruise, and she says, I'm going to a cruise, so can you take out some saline so I can eat more? So there's pluses and minuses. And now the Roux-en-Y. The Roux-en-Y is a very interesting procedure, is because if you take a look at a stomach, it's probably 1 liter plus. And the Roux-en-Y, what they do is they take this little chunk of the lesser curvature. Now it's about 30 mils, so it's about the size of a soft-boiled egg. So you've gone from 30 mils, from a liter to 30 mils, and they take the lesser curvature. And the reason they take the lesser curvature is because it's less distensible, and that there's less acid. It's achlorhydric. So think about the implications of that. So what about B12 absorption? What about calcium absorption? What about how are the different medications going to be, the bioavailability? So these are some of the topics that you have to counsel your patient. And we're going to be supplying a handout at the end of this presentation. Now, bariatric surgery, does it cure type 2 diabetes? Look at this. These are the people that had gastric bypass. This is 6 to 9 year follow-up. And look at that, 8.6% have type 2 diabetes. The controls, 87% have diabetes. So look at the difference. Was gastric bypass successful in decreasing surgeries? Absolutely. And it's not only in terms of diabetes, it's successful in terms of musculoskeletal problems, in terms of cholesterol, in terms of blood pressure, overall, all cause it decreases. But I think the issue is the reason that it decreases is because it keeps the weight off, and that's the whole point. In the past, we did not maintain the weight off for prolonged periods. So recommend supplements for patients after bariatric surgery. Though these patients have an increased incidence of osteoporosis. So what do? Well, we can't give them calcium carbonate. Calcium carbonate is not absorbed, so we have to look at calcium citrate. They also have problems with anemia. Well, again, you're into this ferric-ferrous combination. So what you have to do is take iron with vitamin C. Vitamin B12, not well absorbed. So what do? You have to counsel them. Either they take it sublingually or injection. So this will be all in the handout, but these are very important issues because I think many healthcare practitioners aren't aware of the implication of this surgery. Also, a lot of our patients are going to the States and they're coming back with this surgery, and we don't appreciate the ramification. Canadian guidelines. These Canadian guidelines have been here for the last 2 years. And I think it's important that we follow them, that we educate our patients, and we empower our patients. So what can we do in pharmacies? Well, first of all, I think weight management programs are really ideal and key. And we're talking about therapeutic weight loss. We're talking about 5 to 10% weight loss. We're not talking like 40 to 60 pounds. It'd be nice to have clinic days when you can go through the information, you can educate the patients. I think if you can go with support groups, we can talk about pedometers, sell your patients pedometers. Pedometers are a great tool, and encourage the patients to increase activity. And also, I think it's important, pharmacists are well-respected members of the community, is to go out there and go to the different service groups, offer your services. You can give presentations, you can give talks, you can get more information on the CON website. So I think The landscape has changed. Obesity is no longer a social issue, it's a medical issue. Obesity is now acknowledged as a chronic disease. Obesity has implications on diabetes, on hypertension, on cholesterol, on osteoarthritis, on sleep apnea, on et cetera, et cetera, et cetera. And obesity has to be treated long term. So this is what we have to tell our patients. We have to empower our patients, and we have to make changes now. Thank you.